Good afternoon, everyone, and welcome to our Protect Our Province pop-up briefing for Alberta. We are live streaming from the traditional and ancestral territory of many peoples. We are grateful to live and work in Alberta, a province on the traditional territory of 48 different First Nations and the unceded homeland of the Métis Nation. Today's conversation is not being shared in ASL, but to ensure completely accurate access to information, closed captioning will be uploaded after the live stream is complete. This conversation for the public is being shared live on YouTube, X, formerly known as Twitter, and Facebook. The views of our panelists are their own and do not represent any institutions they may be affiliated with. We have collectively gathered here as concerned Albertans, attempting to ensure that everyone in the province has access to as much information concerning the current state of our healthcare system. Hello, everyone, and thank you for joining us for this special pop-up edition of Pop AB. Apparently, I drank water incorrectly, and so now I'm going to suffer for the next few moments while we get going. But before we get going, I wanted to thank everyone who tuned in last week and those who are joining us this week. We've curated this limited series of popping up to address the ongoing healthcare crisis in Alberta, and we really do value you taking the time out of your day to join us in these conversations. Last week, we spent time with experts whose experience is largely shaped by our province's acute care system and the impact still being felt by SARS-CoV-2. This week, we're turning our focus to primary care and family medicine. Our panelists today are going to take us through the current concerns in primary and family medicine and how it is affecting the public and how we got here, also with some possible solutions, ongoing challenges that we see, and the impact potential changes may have on the humans who call Alberta home. In traditional Pop AB fashion, we will start with a look at what we know about COVID-19 in Alberta this week. We have been internally referring to delivering the numbers as akin to a brief weather update. So if you're feeling creative, feel free to suggest some names for our brief numbers update via whichever social media platform you engage with us on. We began this work to address the concerning gap relating to information about SARS-CoV-2 in Alberta and how to stay safe. Unfortunately, this information continues to be primarily inaccessible to the public. But what we do know continues to paint a concerning picture. Dr. Tara Moriarty's COVID Hazards Index has the level of COVID circulating in Alberta as severe, which is similar to all jurisdictions in Canada, but definitely not low or moderate. And she is currently estimating that 1 in 20 Albertans have COVID. We have leaked inpatient data for Alberta that shows that there have been over 1,000 COVID inpatients in hospital for 30 days. 1 month, and it has been stubbornly stable, neither rising nor falling. From previous data, we know that only 3 times have there been over 1,000 patients in hospital with COVID. That was during the 5th, 6th, and 7th Omicron waves, which was last year. So it has been a year since we have had this many patients in hospital. ICU patients topped out at 40 a few days ago. That's the highest since early January 2022, but fortunately far below from the peak of the Delta wave. Publicly released data last Thursday showed 67 deaths reported over the last 2 weeks, or about 5 per day, which is alarmingly similar to this time last year. I am having screen issues because it is just going to be one of those days, apparently. Or so they say. I don't know why. There's more that I want to say, but I don't have it appropriately memorized to be able to say it without the machine allowing me to do so. Of course, live, friends. It's live. Why? Who knows why it's being so mean? I would like to talk about, well, I know what I was going to talk about. Okay, maybe now. Gotta love technical hiccups. Please just bear with me for a moment, friends. Where's that technical difficulties label when we need it? Apparently no longer with us today. So Michelle will just mad panically scramble through screens. Fortunately, I am okay with not being perfect at any given moment, so I accept it as, oh, I really do have important information to share. Why doesn't it like me today? Don't do it at all. Please stand by. Thank you, Chad, for putting up the technical difficulties pattern. Obviously, I was away from the screen in focus at the moment. Okay. No, nothing. Never. Why? Why? Does it just not want to be my friends? How many seconds can Michelle babble on for? Okay, we will just come back to the end of my COVID numbers update, which I would like to share because it was some really important data relating to the great work that Adam Toy has been doing in terms of what data is publicly available. Adam Toy is a journalist with Global News and has been putting together some fantastic information on what we know about current outbreaks, how masking mandates in Edmonton have been really helped stabilize and reduce the spread, masking mandates in hospitals, not in regular life, but in places where they really, really can make a big difference, and how the rise that we're seeing currently is primarily in Calgary. Oh, look at so there's I've got a lovely message with some of the information that I was going to share. There's a little bit more, but I'll share it anyway. Adam Toy, the Global News reporter, has been following the publicly released outbreak data. While patient numbers have been dropping overall in hospital-acquired infections, that is predominantly driven by Edmonton hospitals, where universal masking has been implemented. In Calgary, where there is no mask mandate, sharp rises in both healthcare workers and patient hospital-acquired infections are obvious. Publicly released data last Thursday showed 67 deaths, which I did cover earlier on. In Calgary, where there is no mask mandate, sharp rises in both healthcare workers and patient hospital-acquired infections are obvious. Oh, I'm rereading the same thing twice. That's what happens when I don't use my own script. Wow, it is just going to be one of those days. I would like to move us forward so we can meet with our panelists that are joining us today. I am very excited to have both of them in the conversation. So I'm just going to bring them up so I can stop babbling at all of you. I am so excited to introduce Dr. Mayer and Dr. Hillner, both of whom have been active in POP AB behind the scenes for a very long time, but it is the first time we have gotten to have them live in person and in a conversation with us. And I couldn't be more thrilled to have you both. As everyone knows, I am a human who does not like to speak for others, so please introduce yourselves for everyone at home and share what lens you are joining us from today.
You bet. Thanks, Michelle. And if you need to interrupt us for breaking news to give your weather report later on, please do. So I'm Sam Meyer. I'm a rural generalist. I currently work as a locum in Sundre in central Alberta, but I've had a busy full scope practice in Pincher Creek from the beginning of my career. And up until last month, I was the section of rural medicine president for the AMA.
Thanks, Michelle. Hey, Sam. I'm John Hillner. I'm a family doctor out in St. Albert. Up until recently, I was the section of family medicine president at the AMA, and coming to you from St. Albert, where our clinic, which has been around since 1966, continues to provide family medicine to around 20,000 patients in the St. Albert area. And looking forward to talking to everyone today about family medicine. And thanks for everyone being here.
We did prepare a bit of, perfect. Sorry, Michelle, take it away.
Oh, no, I was just going to say thank you both very much for joining us and being willing to go through all of this information with us. As one of my primary functions outside of not being able to find my script is picking up on things that humans who are not doctors, i.e. me, might miss the meaning of. This one had come up once before. So Dr. Mayer, what is a locum?
Oh, sorry. Yeah.
Oh, no, that's perfect.
Jargon, please do stop us if we do that. I also realized I said AMA instead of Alberta Medical Association. So I'll try to not do acronyms as well. So a locum is basically like a substitute teacher for doctors. It's somebody who comes in and gives reprieve to communities that need a break, right? Either in the hospital, often both, right? The hospital emergency department and in the clinic. And that's what I do. I go back to Sundre. I'm also based in St. Albert now. Just where I call home, but I make the 3-hour trek because it's an amazing team of healthcare providers there that are providing excellent care to their population.
Thank you very much. So as we move into that conversation and bring up your slides, anybody who is joining us, please remember that if you have questions for our panelists, feel free to post them in the comments section on whatever platform you are joining us on, and I will do my best either partway through the presentation or towards the end of the presentation to work them in. Once again, from all of us at POP AB, thank you very much for bearing with us, and more importantly, for being with us today.
Thanks, Michelle. I'm really thankful also just to protect our province for giving a platform to have this conversation. We think it's really important, obviously, for the health of Albertans to have good primary care. In fact, we know it is. And so, I know this isn't the traditional content, the meeting, and so we're very grateful. So the thing that Michelle said in the beginning that struck me was the purpose of POP AB really was to fill a gap in the info that the public was seeing. And that's why we're here today too, because we feel like there's a very big gap in information that reaches the public or even, the healthcare workers in this province. And the kind of things that we were, privy to in backdoor conversations or, what we've had or heard directly in conversations or brought directly to the Minister of Health, the Premier, et cetera, right? This, just going to the title slide here, it really doesn't jive with some of the recent announcements we've heard, right? So it sounds like everything is great in primary care. It's all fixed or soon to be fixed. And that includes the announcement this morning where we're apparently very close to a solution, unbeknownst to all the healthcare workers who are slogging through and don't see an end in sight. So I recycled this graphic from a talk I gave 2 years ago to SACPA, so the Southern Alberta Council of Public Affairs, which is a great platform for having these kind of conversations, open, honest, public focused, because this all affects you, the public. These were words that were sent to me by real physicians in rural Alberta. It's how they felt at the time. It is definitely how they still feel. We get that all the time. It's how we feel, like we're not being heard, we're burnt out, no one cares, there's no say in the system, et cetera, et cetera. But I've talked too much, so go ahead, John.
I was going to say, I think there's a few words that jump out at me in this as well. And, some of those are things like exhausted and powerless and having no say. And I think that part of the reason I'm thankful that POP is doing this is giving you all and us the opportunity to share information so that we can all work from the same place and make the decisions around whether we feel like what is happening around us in healthcare and to our families and ourselves is what we want from our system, or whether we need to ask for better. And we're hopefully going to give you some context today so that you can do that with understanding and knowledge to ask for what you really need.
Yeah, and I think go to the next slide there, Chad. Thanks. So we've broken it up into really kind of what is the problem. We're going to try to give you some good news too. We'll sandwich that bad news with a silver lining, hopefully at the end. And then we're really happy to take questions, because that's what matters to us, is that you're getting the information that you need. So we'll try to leave a lot of time for that. We really struggled with where to start, because there's so much that we could talk about, but we figured we'll give you the overview and then we'll go from there. So next slide. Yeah. So what's the problem? Go ahead, John.
So this I think captures where we're at. So for anyone out there who has unfortunately lost a family doctor or tried to find one, you may find that's really difficult to do right now. And you're not wrong, and you're not alone. Right now, there's a drop of about 78% of family doctors accepting patients across Alberta in the last 3 years. And so you can see there that there's only around 190 doctors that maybe are accepting. And the important thing is, even those numbers aren't quite right. So when you do phone clinics that are supposedly accepting patients, you might not be able to get in. If you have complicated medical issues, you may feel like you're going through an audition process to try and get help and get care. And for those of us who are practicing family doctors who really want to help, and who are getting pleas from our own patients to take on family members and friends, or from people outside of our clinics to take on care, when we're not able to, it's hard for us too. We really do want to be there for Alberta, but we can't be there for everybody. And so it comes down to a supply issue, and that really comes down to supporting family doctors to do the work that we do and bring people into the province. And so I think, when you don't have a family doctor, or you have one and you can't get an appointment, just remember that this is across the whole province, and hopefully have some patience with us as we try to get through what we can to help you out.
Next slide. Thanks. So this is the data from a survey we did last spring of our own current family doctors. These are people who do have a panel, do look after patients, and we asked them, so what are you planning in the next 3 years? What do things look like for you? And the response was pretty in line with what we felt, and also some national data, but it is quite concerning for the province. Like, this is 53% of respondents telling us that they're going to reduce access to care in the next 3 years. And, we're already half a year into that. And a lot of them told us, if we don't see help in the next few months with the new government, that's when our decision is made. And so the really terrifying part with this is that a lot of these people are just, really new in their career. I'm only 5 years in myself, and I have felt many of these things and thought many of these things myself. And I have changed. I changed to locum work too, and there's a lot of reasons for that, and we can talk about some of them. But for now, it's really about forecasting the workforce crisis to come, because it doesn't just end here. Next slide.
So these are some of the things that our colleagues across the province are saying, and we had thousands of responses to our survey. Some very heartbreaking stories, and just reading what our people are saying. Morale is low, patient care is suffering. I've never felt this much desperation in the 34 years of practice in this province. That's something we hear consistently from a number of our colleagues who are toward the end of their careers, that they haven't seen the system looking the way that it is now, or felt the desperation that we do. I've already given up most of what I used to do, including primary care practice, to do only niche work due to this government and how terribly they've treated us. I feel discouraged and severely undervalued, to the point where it seems like it's not even worth continuing to work here. And I'm going to pause there just to highlight what niche work might mean. So typically when we talk about family doctors, we think of a family doctor who has a group of patients who they look after from, cradle to grave, and provide care from when they're babies all the way up until it's time to start approaching a dignified death. And that isn't the case for all family doctors. So family doctors work in settings in hospitals, in emergency departments, in rural settings. They might do all of that, as well as obstetrics. And so there's a few different roles that we fill in the system. And so when you hear some of the numbers that are coming out from government around how many doctors they're recruiting, it's often misleading. It doesn't represent the real situation. And I think all of us feel that when, we hear about how many people are coming in. That's the number of doctors that are licensed, but we don't see that change in access to a family doctor, or being able to actually find one for ourselves.
Yeah, and we heard over and over again from our people that if something's not done fast to compensate, family practitioners, family medicine will cease to exist. That's how people feel. Like, family medicine as we know it, right? That cradle to grave, the comprehensive care, the one-stop shop where you can come in and talk to the same person that delivered you, often in a rural community, right? And will, if you're lucky, deliver your kids for you. That continuity matters for a lot of reasons, but because healthcare is scary, right? And relationships make it easier when you know and trust the person that you're telling really private things to. That can make it a lot easier, especially for a lot of our marginalized, vulnerable populations. Next slide. So, why are people feeling undervalued? Because we are, right? Primary care receives less than 8% of the budget, and they deliver over 50% of the care, up to 70% in some studies. So that infographic on the right, the blue box at the bottom, is just meant to represent how much of what happens in the system on a daily basis is done by family medicine. Because when we say the primary care, that's not just family medicine. And so that 8% is also going to a lot of things like primary care networks as well. So it's even less that's actually going to the docs on the ground. And then that blue arrow linking to the black bar, that is, this is a graph of the income equity, or we'll call it inequity curve. So these represent different types of physician work. different specialists, and the family medicine specialists are that black bar. So we're to the very far bottom of the pay scale for the work we do, and a lot of our docs, and certainly we've experienced this, feel like we have the highest responsibility. It's a 24/7 job because you're always responsible for investigations and being that safety net for people to make sure that you guys don't fall through the cracks of a system that has a lot of cracks in it, especially these days. Next slide.
So this has a lot of numbers on it, but I'll draw attention to the red box there. So what this looked at, it was actually a study done in Nova Scotia, looking province to province to see what the supports have been like and how they've been adjusted over the years from 2018. And you can see that it goes into the future because that includes some of the agreements that have been signed with doctors. And you can see that over time, Alberta has had a very, very slow progress of investment when it comes to family medicine and into physician services budgets. And so family medicine is a part of that. There's also a box in there that says that the overall fee reduction is currently unknown. And this really comes down to some of the information that we think is important to share, which is that in the year of 2020, 2021, largely because of the pandemic, issues with a torn up agreement and virtual codes that didn't respond to the needs of family doctors in providing care for Albertans. The amount of money that the government saved off the backs of family doctors was just over $200 million. And that was despite each doctor doing more services. There were more services per physician done, per family physician done, but 200 million less in terms of pay. And that also contributes to why your physicians are leaving, why they're choosing to close practices that became non-viable, or why they feel undervalued in the Alberta healthcare system.
Thanks. Yeah. So, I mean, the reason to highlight that in particular is because it shows the instability and the relative lack of valuing the physician workforce in Alberta versus other provinces, and that has an impact on our learners. So, like you might have heard about, more medical schools, residency programs, or spots, right, as a part of the solution, but it's only going to help if they want to stay in Alberta. Otherwise, we're just using Alberta taxpayer dollars to train physicians for everywhere but our province. And the other caveat to that is that even if they do stay, there's no guarantee that they're going to take on a panel. And our docs have been very clear, and the students and residents learners that we talk to, why that is, right? It's not incentivized above any of the other things you can do in medicine with a lot more responsibility. Is it rewarding? Absolutely. There's a reason that we've been doing it despite this, right? And that people are, like, we've heard everything from filing bankruptcy to remortgaging homes to keep their business going, to look after patients because it matters to them. But it's a pretty sad state when your professionals are in that position. So,
Is a panel a list of patients, like how many you choose to carry with you and see?
yeah.
Yeah? Okay. Okay.
It's your list of people that are you're responsible for. Ultimately, you're the most responsible provider for that patient panel. And so when we talk about teams, that's really important, actually, because when you talk about teams, the physician, or in some cases, the nurse practitioner, is the most responsible provider for a panel. And so everybody that works in that team to see the patient, it's still, the buck still stops with that most responsible provider. And so there's a lot of responsibility, again, even if you're working in a team, to know what's going on in all aspects of that team to make sure people are getting the care that they really need. But the even more depressing next slide.
So this captures the numbers for what we call Karms, which is our residency match. So this is, when you do medical school, you go through your medical training, and towards the end of your fourth year, you have to make a list of all the places that you want to work and the areas that you want to work in, and then you apply and you interview and you travel across the country, except in COVID, where it was a lot of virtual interviews, and you find the place that is going to be the best fit for you, ideally. And so the way that works is potential residents, students at the time, rank their list of places that they want to go. And the places that are looking for residents will rank the students that are applying, and this process matches them. And what happened during Karms in the last few years, you can see in those red bars, is that the number of unmatched spots in Alberta has grown significantly. And you can see there's a step up jump in about 2019 and through to the present. And most recently in 2023, we had 42 unmatched spots. And so the question then becomes, well, if we increase the number of spots, but we're still not filling them up, how are we going to fill in the need for family doctors over time? And when you talk to students now and incoming residents about what some of the concerns are, the cautions and hesitancies in Alberta, a lot of it comes down to stability. Some of that was stability disruption by tearing up an agreement. Some of that is promises that have been made and not kept to physicians. And more recently, we've heard some of the deconstruction and reconstruction of the healthcare system that's being planned at a time where we really weren't resourced to get things done in the first place. And instead of resourcing and supporting what's here, we're now shifting and trying to refocus and tear us down and rebuild it. And that causes a lot of uncertainty for people who are looking at their futures and deciding where they want to be.
Yeah, and I think I just want to add, so those two different color sets on the graph, that's one was University of Calgary, one was University of Alberta, so it's it's throughout the province. We've had some of the most competitive programs, like they're great programs. The people running them do a great job. We both trained in Alberta, and can't say enough about good things about them, but it's the reputation and people not wanting to invest in a place with so much uncertainty, which is why, part of the reason why we're here talking to you today, because it is so disruptive to do this refocusing that John mentioned, right? Because we don't have, if any of you participated in the town halls or have asked questions yourself, that we're not getting any answers. We know some of the behind the scenes stuff, certainly for primary care. We were very involved in the Modernizing Alberta Primary Healthcare System process, but even that was very vague despite us putting a combined 300 hours into giving feedback and reading through that almost 400-page report multiple times. We'll get to that, I guess. Next slide, you'll see our fun attempts. So, right, time for good news. So the good news is we know it works. Next slide. We know that continuity, so that is when you see the same provider, you have that same, we talked about the most responsible provider. So if I was your family doctor, if you come to see me 80% of the time or more, that's considered high continuity. And so this graph is showing the increase in unnecessary emergency room visits. So those are things that could otherwise be prevented if you either have moderate or low continuity. So the more other providers or other places that a patient goes to see, other than having a single source who knows them well and has a record, understands their social situation, what's going on at home, knows what medications they're on. Like I can still recount, I haven't had a panel for a couple of years. I still recount the histories of the people that I got to know very well. So that matters, is what we're saying. That's continuity. And we know from a ton of evidence, we just pulled here evidence that was from a study that happened in Alberta about 10 years ago, that it saves a lot of money, right? But it also saves lives. So people are healthier for longer. It's the only part of the system where there's a consistent increase in the amount of healthy days you get to spend as a human, as Michelle would say, right? Or just days in general that you get to be alive with your family. So, investing in family medicine literally saves you and your family time together. And so there, you can see we gave this information to the Minister of Health, right? She's seen it. And the idea is to show, this is where you need to invest. We know this stuff. Like, we've known this stuff for 2-3 decades. It's just trying to get governments to do it is a different story, because it's not as flashy as opening a new hospital or cutting a ribbon, right? It doesn't really jive for the press releases or the, and fancy announcements, but it is the kind of stuff that matters. The next slide. It doesn't just matter with emergency, it matters with hospitalizations. And if you don't know how much it costs to stay in the hospital, feel free to let your jaw drop. And this was 10 years ago, right? So assuming even higher now, but these are just some estimates of what you can save by avoiding again, these are unnecessary hospitalizations. So they're things that if you have good continuity with your family doctor in this case, over a period of time, there's a less than 1% chance that you would find yourself hospitalized because your chronic condition is well managed. And right now we have people who have nowhere to turn but emergency, or or they're going to the pharmacy walk-ins who they're not equipped to deal with a lot of these things. They can't, and because that's not in their scope. Like, it's not at all any slight on our other professionals, but the government is putting them out as a substitute for something that we don't have currently, where they're really a supplement to your care. Like, there's something that we should be adding in an integrated, team-based fashion, and instead it's like here is a clinic you can go to. What did you say, John? Like, if you wouldn't go there for
Yeah, I said if you wouldn't go there for a pap or a rectal exam, is it really your home base for care?
Yeah, it's a screening matters, right? And so that's kind of the litmus test in my mind. Is it a place that's also looking after the stuff that could cause you problems down the line, not just your thing you're there for at the moment? Ideally, it does both. Next slide.
So the question is, how do we get people here? And I think that's the other piece that we know the answer to. So we've seen this happen in BC. So to give you a bit of context, BC was in a state where even fewer people had a family doctor, and people were getting to the point where you'd try to go to your clinic and it would be taped off and have a sign that says next clinic down the street, and you'd go there and it would be closed as well. And it got to the point where so many people were without a family doctor and demanding one that they actually made a difference and stood up with a new plan. And so the group of family doctors in BC, the BC Family Docs, along with their medical organization and the government, worked together to come up with a plan for how to support and fund family medicine in a way that would reflect the needs of people in care. Next slide, I think.
Oh, wait. Can you
go back?
Because I think it's important just to highlight, like, 1 year
What
after
happened,
it was announced. Yeah, like, the outcome was 6. So this is 600 new people practicing in this longitudinal family medicine that we're talking about, the kind that's like your one-stop shop, knows who you are, right? And 75% of the existing doctors signed on voluntarily, right? And so when you have people voluntarily choosing a model that is really important, that tells you you're doing something right. And so that's dealing with a lot of that demoralization or that feeling undervalued piece. But those 600 doctors, they're coming from places like Alberta, right? But they're also people who are being drawn back into longitudinal care who might have left it in BC, which is exactly what we want to see here, is people who are trained and ready to do the job, right? That can come in and join practices and expand capacity right away. But the model did a lot of things. We can talk about that later in more detail. Oh, like now, go ahead.
So this actually highlights what it does. So the things to kind of note on this is that currently for family medicine, the way that we're paid is we're paid on mostly on a fee-for-service basis, which means that when you see your family doctor, they're paid for the service that they provide for seeing you. What's not covered is what's not covered is the extra administration time. So the time that it takes to write notes, send referrals, to keep track of the records for you, as well as a number of other administrative tasks. And we're also not supported for the teams, which we recognize are really important. At our clinic, really proud of the team that we have. So we work alongside shoulder to shoulder with a pharmacist, with mental health nurses, with nurses, as well as our staff who pitch in to help out with care. And it really does help. When you leave the hospital, you get a phone call from our nurse who reaches out to make sure that you're looked after when you leave. Our pharmacist will go through your medications and make sure that you have enough till when you see the doctor, because sometimes that takes a little bit longer than intended. And our mental health nurse can help out if there's any concerns that weren't addressed from a support side in the community. And so you kind of get that wraparound service, and that piece is those positions are created as salaried positions out of what doctors are paid. So that's part of what we call overhead, but really is supporting the people that help us do our work to the best of our ability. And so this model, I'll get you to put the slide back up. So this model pays for the time that it takes to see people. It pays for the encounters. It also pays for the challenge of looking after more difficult or complicated conditions and how they interact with each other, and for the teams. And it ultimately, what we've heard from our colleagues who have made the decision to migrate to BC is that they feel respected, that they feel that this model reflects the time that they're doing and the effort that they're putting in a different way.
Yeah. So next slide. The pleasure of going back to the bad news. So we're not doing the evidence-based things. And I think people know that, it doesn't jive, right? To see the excited announcements about how everything is fixed and how this is going to be the way forward. And we have a map to someplace that's going to be great when we get there in several years. The solutions are so simple, but what we're doing looks more like the next slide. This is, I don't even know, John. This was John's attempt to graphically show you some sort of structure from the 377-page MAPS report.
Yeah, we're not going to belabor this, but I think, if looking at this, it looks overwhelming, confusing, crisscrossy, and has lots of words. And I think that, when you look at the MAPS report, if any of you have tried to dive into the 377 pages, alongside what we've heard recently around the siloing of healthcare into 4 separate structures in Alberta, it really moves us further away in some senses from where we need to be in supporting what already works well and what exists. And so we'll come back to this if there's an appetite, I think, to go through it in more detail. But maybe what we'll move on to, we'll get you to change the slides there, and we'll talk more about kind of what we've seen happen in terms of what's been told to us and what actually happened. So what we've heard several times now is that we're in a family medicine crisis, a healthcare crisis. And, we don't respond to crises generally a year later. I can only imagine the devastation of responding to the crisis of something like a forest fire in a year. We've heard that there are going to be immediate actions to address urgent issues and give you all access to family doctors. But what we've seen is a task force leading to a task force, and a pinky promise that we're going to start talking about, thinking about, planning about doing something. And we've waited. What's that?
Maybe at the end of that.
Yeah,
maybe in budget 2024.
In 24, yeah. And so I mean, even, if you look at what happened today, we had an announcement this morning around nurse practitioner funding that really didn't add anything new to the conversation. This was a re-announcement of the same supports that have been committed already, with a promise to start working on them in 2024. And after, we hear these things over and over, we need to start asking ourselves, like, how do we make sure that we actually act on the promises that are being put forward?
Yeah, and I think, like, the other important piece to highlight from this is that, like, during the MAPS process, there was no real support, like stabilization measures that were tangible, right? So the things that were announced as in conjunction with MAPS are things that actually came after the fact, largely by us because of feedback from our members, right? Taking proposals for stabilization plans and, an Alberta LFP model, so like the BC one, because that's what we're hearing that people need. And so taking those in a very concrete way and putting them in front of the Minister of Health, having those discussions with the Premier, giving, very concrete numbers as to what we would like to see, right? And that was happening in the summer. And so to see these things come out now and just be like, oh, and also they were part of MAPS is not true. Like, it's just not true. And we didn't talk about the dissent at MAPS because there were a lot of physicians there who didn't see how this was going to help their patients, couldn't see how it was going to help them continue to practice with their big teams, right, that they are currently funding mostly themselves, right, because they know it matters for good care. And, in fact, it felt a lot like watching doomsday get closer and closer, right? And people talking about, well, okay, if this actually goes forward, I'm going to leave, and here's my exit strategy. So that's the opposite vibe that we want to give, right? It's like we want things. We were looking for what is going to give people hope that there's going to be real investments in the kind of care that we've talked about today. And then how do we get those to the people that need it so that they can help the people that need them? But next slide, because there's more fun myth.
Before we go on to the next slide, though, could you, because I don't think it actually came up, what is the long form of LFP in the BC system?
Yeah, the longitudinal family practice, and it's a
Longitudinal family practice. Okay, thank you so very much.
fancy way of saying
Combine
yes for a work to look after you over time.
and my follow-up sort of on that is, so as this ongoing conversation has been happening over the last many years around the crisis in family medicine, how did, in, I guess, short form recap, how did it get to the place that MAP existed? So was it a situation where the government went to family doctors and said, hey, how do we help you stabilize? Or was it a situation where you guys were like, please let us help you stabilize? And then just sort of the, 5 points as to what led us to this modernization of Alberta's family or primary healthcare.
So maybe I'll take this one. So I think what really got us here was in 2020 our agreement was torn up, and we spent the better part of 2 years through a pandemic without an agreement, lots of uncertainty about how we were being paid with underfunding, and we got an agreement ratified with government in September of 2022, and that agreement came with some promises. It came with a promise to invest in primary care directly. It also came in with a promise from government that they've volunteered to start the process of MAPS, the modernizing Alberta's primary healthcare system, to add more funding and supports. And that was how it was sold, as well as promises for additional funding for some of the wraparound services in Alberta through primary care networks, which provide some of the team supports and team funding, among other things. And so this was something that the government, was an initiative that government started, that we went through hoping to provide input and direction on. And then that process concluded in March of 2023. And then there was radio silence until most recently in October, when, as Sam highlighted, announcements were made, many of which weren't really a part of MAPS. And in between that, there was another commitment to investing in primary care with the then minister, Jason Copping, who had said he was going to invest, or the government was going to invest, $243 million into primary care over the next 3 years. And now that number has seemingly changed to $57 million. And we find ourselves at today. Thanks, Michelle, for the question.
What a
Thank
recap.
you.
Can I
Thank
add
you very
things to it?
Please, Dr. Mayer, please.
Well, so when John says radio silence, it was also enforced radio silence. So it was all non-disclosure agreement, and like very much like a don't you dare talk about any of this to anyone. Like we couldn't talk to our executive members that help inform the direction of the sections, right? Like the Alberta Medical Association Board of Directors didn't have access to the MAPS report. Like, this is the future of primary care in the province, and it's not actually like being shared or discussed at any level there. Like I said, the dissent wasn't captured. It was basically just what amazing consensus we have in this report, unprecedented consensus. And we said, like, dissent is important. Like, it shows you where where you need to have ongoing discussions. It doesn't take away from your product. It actually strengthens it to show that you've thought about these things. And so we've really been left with the same questions that we had at the table, which is also frustrating and demoralizing. And I'm just going to add in it's not speculative. There is lots of stuff to back this up. Including documents that we haven't shared, right? But this was a lot of it was predetermined too, right? And when John says it was a government initiative, there was not a lot that changed from the beginning to the end of it, despite those 300 hours of input between, and many more from others, right? And lots of talented experts. But the meat of it, right, is really around the governance changes. And I think what we've seen now in acute care as well, AHS, is that there's an intent to change the structures and the way the governance happens and the way, money flows and decisions are made. And that's that uncertainty piece. But there was really no appetite to consider like other things that were being put into maps. It was just what do you think about these very concrete things? Okay, great. We're just going to put it in our report now. So it was pretty disappointing because I think there's a lot of people who really do have a lot of good ideas and passion for improving it, and and we kind of lost, or we squandered that a lot of it. Yeah. When else do you get public members and like all of the allied health providers and a bunch of like technology and innovation experts there in the same room to talk things out? Like, what an opportunity.
Thank you both for clarifying that for me. Now I'll let you have your next slide.
More promises.
So this one actually goes back to our agreement back in 2022. So there was a promise from the government to make sure that if patients show up in an emergency room or at a hospital and they can't prove they don't have their healthcare card on them and can't prove that they have a healthcare card, and the doctor says, I believe you, I believe that I'm going to get paid to give you your care even though you don't have it. I'm going to treat you and make sure that you're looked after. We call that a good faith claim, and those were taken away by this government in, correct me if I'm wrong, Sam, 2020 or 2021, and that was supposed to be added back in our agreement in 2022. And we've had several announcements now saying that they're going to come back, and we are waiting to see them come back in, which has left many docs waiting for payment for services that they've done out of their goodwill.
Yeah. Next slide.
How long does your current agreement last?
Is 2022 to 2026.
Thank you.
So I mean, this expanding the virtual mental health codes again was another like strange re-announcement. It must be the third or fourth time that we've heard this particular announcement. It is just another undelivered part of the agreement. And I just have to add, like, other provinces have had these for years because they appropriately supported their workforce through a pandemic. And that is what it was meant to do, was keep people safe, right? And make use of distancing. In COVID, we find, there are a lot of good uses for it. It allows people to reach populations that maybe wouldn't have been able to come in or whatever too. Like, it's important to adequately support it so that patients are getting the care they need. And I will also add, we had no problem appropriately paying for TELUS Babylon to do the same thing. Next slide. Go ahead.
And then the more recent announcements around this 57 million over 3 years, and again, this was reannounced today. It was a support for both family physicians and nurse practitioners, and the key with this is it comes with strings attached. So the reality, we think anyway, we haven't heard all the details, but it sounds like the reality is that in order to qualify for this funding, you would need to take on additional patients. And as we highlighted earlier, many of the doctors that have a consistent group of patients that they look after or a panel are full. and don't really have that capacity to take on more. And if they were to take on more, that would affect the ability for people who they were already looking after to book an appointment with them, and it would make that wait time longer. And so the people that really need these sustainability funds, these short-term supports, are not likely to be the ones who are able to access them, which leaves people in the same situation, doctors and their teams in the same situation that they were in before.
And just for context, BC did a stabilization fund before they put their longitudinal family practice or their LFP model out, and I think it was 117 million for 3 months. Right, like it's rather than 57 million over 3 years. And as we highlighted before, in a single year, the government saved over 200 million from family medicine alone. So when you know all these things and you've been in all the rooms and you see the announcements, you've had the discussions directly with the officials, and then what comes out is just doesn't look at all like what went in, right? Or maybe it just went in and out without processing. I don't know. It's very frustrating, disappointing, and it's infuriating because we know how much it impacts the care that Albertans are able to receive. And it's just every time these things get reannounced, people get more and more demoralized because it feels like nothing real is coming. So yeah, next slide.
And so I love this. Yeah. So I think the one thing I would say is both of us believe that Alberta has the opportunity and the place to be a leader among Canadian provinces, and probably an international leader when it comes to primary care, if we're willing to do some of the things that we've talked about around investment. And so we really want to turn things around. We want people to run the other way and come back to our province. I'll just get you to change the slide there for us. So we've seen this work in other places. So in BC, as I alluded to, they'd gotten to what was essentially rock bottom, and people stood shoulder to shoulder with their family docs and went to the legislature on Family Doctor Day on May 19th and demanded care, demanded a family doctor and access. And you can see there, no care and bad care don't equal universal health care. And I think that's so important because we cannot leave behind people who need care. Our populations that typically are not looked after as well as they should be. We'll go to the next slide.
But yeah, we've done it here too, right? That was a younger, more hopeful me in Pincher Creek. I put that up because we had such an amazing community wraparound support rallying for healthcare, and I think that's what we need to do, right? Like we need everybody to go to their, if they're lucky to have a physician, to go to their physician and say what, or their clinic, right, their healthcare team, and say like, what can I do to help? And if you don't, right, so we need you to be keeping track of your attempts to access care, right, and talking to the media. Like these things work, right? In 2020 we were able to like basically prove that some of the impacts that we feared were coming were going to create closures in up to 44 rural communities. And all we did was really collect those stories and put them forward in a concerted way, right, in a unified way. And everybody's favorite Minister Shandro there, like within 4 days, I think it was, of the announcement coming out, Rural Caucus had pressured them to turn that around, and they did, right? And unfortunately, we knew that it wasn't going to turn the province around, right? We never wanted things just for rural, and we didn't have an agreement still, and there was still so much uncertainty. But at least it kept those communities with their hospitals for now, mostly. I think the other reason I put that picture in there is the last time that I drove by that sign, there was tape over the emergency room because it was closed for the long weekend. That was in July. And that's exactly what we've been fighting to avoid. And I know that there are communities that have lost their emergency rooms and hospitals entirely. So it's like, we're not okay. We're not close to fixing it. We're not even close. And we need your help, I think, to be involved, to pressure the people to say things honestly. Next slide.
While we're talking about media, however, I will say Julie from CBC is with us. Julie, if you have a specific question, send it to me and I will make sure that it is asked before we say goodbye today.
Yeah, so these are just a couple of options. So the code on the left, if you scan it, you'll be able to access the place that you can search for your MLA if you don't know how to get a hold of them already, to tell them your story, whether it's a story of hope and joy of your experience with family medicine and care, or some of the stories that I saw coming up in the chat, really tragic, horrible things that have happened as a result of not having supports. And on the right, for any of our physician colleagues watching this, you can scan that code to join a group of grassroots physicians who are really keen on getting the ball rolling on supports for family medicine. And I think we probably should open it up to other questions. I know there were a few in the chat there.
There are a couple that have been answered as we've gone through, and a couple that have not. The first one that I wanted to touch on is, do you feel that the announcement of more utilization of NPs, nurse practitioners, will help reduce the burden on family physicians, or is it going to complicate things in new, fascinating ways? Obviously, we don't know yet, but just sort of what your feelings are.
Well, I mean, I think it could alleviate the burden. Unfortunately, how it's been happening and rolling out is not how I would foresee it alleviating the burden, right? Like we could have done things in a collaborative fashion. In fact, we've asked for that repeatedly, and there was a consultation process. Maybe John, I'll let you talk about that more.
Yeah, so I think there's still a lot of unknowns, Michelle, as you said. There's we still don't know what this is going to look like. We haven't heard what this model is going to do to support nurse practitioners. And I think the big question is, should nurse practitioners be supported to work to their full ability? Absolutely. And should that be done in the context of a team where we can all work collaboratively and make sure that we're not missing anything or letting people fall through the cracks? That should happen too. And so doing this work to build structures to pay different groups in different ways and siloing them from each other, I don't think is going to result in what we hope for, which is an ability for our healthcare system to really support people and wrap around them. And so we don't know whether it's going to change things. We heard some of the numbers today around nurse practitioner panels and supports, and where this is going to change. And it will, if some people can get access to a nurse practitioner, it will help a little bit, but the numbers aren't huge. And to put it in context, there's about 700,000 Albertans right now without a family doctor,
or a million is the last I heard.
Or up to a million, and the numbers are not going to be that great for attaching people. And what we want to avoid is not losing the attachment that we already have for people who currently have a family doctor, who, like we highlighted, stand to potentially lose them or in part not have that care.
Yeah, I think so. You were nicer than I was going to be, John. So I'm going to go and highlight, like, there was a consultation process that was half done. And I don't know if they're going to pick it up again, because it sounds like they haven't worked out all the things anyway. But John was a part of that, and there was supposed to be meetings with NPs and physicians and the consultant, and then we conveniently just forgot about that part to moved ahead with all of the announcements instead. And I think what John was saying when he talked about we don't want to lose what we have is that it is very difficult as a physician to watch this happening and watch the rhetoric as like we're replaceable. Like, our training is different. Like, I work with an NP. I've trained under NPs in BC. Like, and I wouldn't have known the difference at the time, right? For a family doctor, like nurse practitioners are awesome, but they're not physicians, period. And more importantly, none of us work independently. Like, we all work in teams. And so this like drive to have the independence part is the scary thing to me, because I think that's going to end up with NPs in a situation where they're not as well supported by their physician colleagues as they could have been if there was a collaborative effort. But to me, it feels more like an intent to be divisive by the government. And we've heard them talk about it's just a cost-effective or more like basically lower paid providers that they think do the same thing, and that's not true. Part of the beauty of NPs is the time they get to spend with patients, right? And all the health counseling that they can do, and that takes long appointments. And so if anybody thinks that they're going to be independently practicing under a government model with a contract or whatever, right, where you have to apply and then you have to have a certain panel, it's going to be, oh, and also you have to see this many patients a day and you have to do this and this, right? Like, I worry about what the ramifications of that are going to be. Are they just going to be facing the same problems that physicians are? And then the other part is that there seems to be a desire to build the team supports in for other providers, but that's exactly what we're asking for, right? Is more remuneration so that we can envelop the team in existing clinics, which will allow us to expand the capacity even more. Like, it's a no-brainer to me. We actually, with the LFP model, design it such that we left room. We said, this is where we see NPs fitting in this. We'd like to talk more about what that looks like and what they would prefer. Radio silence there too.
If you are an NP who is part of our extended Pop AB circle, feel free to drop us a DM at some point or an email. I know deep down this conversation will be ongoing well past today and well past this current series of pop-ups. So it would be great to be able to connect with some NPs in the community who might be willing to join us for some of these more specific questions for your practice and what you hope will come from it, what your fears are, and what you feel like that could look like. Before we say our goodbyes for today, sort of as a summation of all things, the crazy, wonderful silo slide, Dr. Hillner, that we talked about before. Part of this is coming from Julie at CBC. Part of this is coming from me. So we talked a bit about the province's restructuring plan for family medicine overall, but it would be wonderful for all of us if you could summarize your thoughts, how you think it could impact the delivery of family care medicine, and what's next. Maybe what you'd like to see too, which might not be what's next, but just sort of that brief overhaul of where it sounds like we're heading. And yeah,
and I think we talked a little bit about this earlier, but you really can't fix family medicine care and access through a structure. And the key really is to support the work that's ongoing. I would hope to see that the next steps are a significant investment in stabilizing what we have. We've talked about the losses we've had. We've talked about the cuts we've seen in family medicine. There's a lot of people hanging on, but how much longer they'll hang on, I don't know. So I think the first step is definitely to stabilize what we've got so that we don't lose it. And that's not going to happen if you start putting more demands on people in the community to do more, especially if it's doing more with less again. So the if you look at kind of how the MAPS report is structured, when you go through the governance structures, in order to function as a family doctor in a clinic, you would have to come up with a business plan at the clinic that you would then have to submit to a level above you, that would then have to work alongside a bunch of other levels above you to design a plan again together, and then that would have to be approved by the primary care silo. And so somehow in that process, you've also got to look after patients. And we talked about the administrative burden we already have, which is about 30% of the time family doctors spend is on administrative tasks. And so you're asking for an increase in that, which is only going to accelerate the panel drops and changes that people have already highlighted that they would likely go through in 3 years. So I think the potential impact with this is I can understand how government is trying to create some place to go for family medicine, but there are so many layers that are not well defined, especially in the report. When you start reading through it, it becomes very confusing. And that makes it very difficult to know where we fit. And again, it comes back down to stability. Our system isn't perfect, but part of that is because it's never been supported to do the things that it needs to do in primary care. And until you do that, until you support it, you're not going to realize the benefits of family medicine that we highlighted with reducing hospitalizations and emergency wait times, until you actually put some support in place to the people that are doing the work.
Yeah. And I want to add too that like in the plan, there's talk of, slashing the number of PCNs essentially by half to the primary care networks and making these new regional health ones, right, the RHPCNs, responsible for even more than they already are, right? And we know that our primary care networks have been funded at the same level for the past 10 years. It's not appropriate for the increase in services that they've been providing, but the need to do that has pulled the funding that they were able to give to the clinics, the patient medical homes, for supportive team, right? And so there's lots of things like I would like to see a separation of some of the things that the government has forced us to be in competition for resources. There's lots of nuance there. We could probably do a whole episode on that, to be honest. But I think like we haven't supported our PCN structures to give fulsome wraparound supports. There's lots of opportunity. My ideal scenario is a community led sort of PCN structure, right? Or at least where there's community input, like participatory budgeting, where you get a say in what your community needs. And where like maybe one of your municipal leaders is involved at the board level. And so there's elected accountability to the community level. There's so many places, great places we could go to make sure that like the voice of the community is heard. But what we see in this is more top-down control. And that's the same for the AHS restructuring too.
Thank you both very much for all of your time with us today. I am very sad that we have surpassed our moments together. I know that this is going to be an ongoing conversation. Hopefully, though, maybe fingers crossed with a positive end. I've heard this government say many times before that they like to reduce red tape and save money. And it seems to me that a lot of the solutions you spoke of today would do both, as opposed to some of the proposed solutions that seem to increase red tape and cost money. So I will.
Can I say one thing, Michelle, about that? Because I think it's like government's already added 319 FTE to push this plan forward, the restructuring of the so that's the backdoor stuff that people don't see, right? So while they're doing and this is the acute care side, I mean, it also takes into consideration the primary care organization. This is obviously linked with MAPS, right? Like the two things go hand in hand. But while they're outwardly saying, yes, please show up at our town halls, tell us what you think, immediately when the announcement was out, so was the call for 319 new positions in a new structure internally to drive this change, apparently whether we want it or not. So now's the time to speak up for sure.
I have nothing polite to say.
I'm sorry. We're supposed to end on a silver lining.
No, I'll end on a not silver. I don't actually know what to call this one, but we had mentioned briefly the last time you drove by the Pincher Creek emergency room sign with the closure notice over top of it for that weekend. We know that has been an ongoing problem in emergent and urgent care centers throughout, as well as obstetrics throughout the province, particularly in rural Alberta. Has Danielle fixed healthcare yet.ca does have, there's a picture, does have, does have a counter around various things like that. And there are some really wonderful humans online that have been publicly sharing which ERs and urgent care centers are closed for each week upcoming and what has been closed since the beginning. We often do, but we will share that on our formerly Twitter account for anyone who would like to be following along with some of those wonderful humans, because I half the time can't read them, especially because they also are generous enough to track how many kilometers you would have to go to seek care. And so with your ER being closed this weekend, your next stop is 96K, your next stop is 136K. And when you need urgent access to care, what if you don't have access to a vehicle that day? What if anyway, there's many, many unpleasant things that I could say, so I will stop saying now. I think it is also really important that those of you who've joined us today and for the archival records that we keep in mind this day of May 19th. It is too many months away but better this year than not. And so, to all of the folks behind the scenes at Pop AB, as well as anyone else who may be interested, feel free to reach out. Maybe we can do some grassroots organizing, letting our family doctors, and more importantly, the government we elected that uses our taxpayer dollars to fund these services, know how important, holistic, competent, all-encompassing, complete family care is to us. And with that,
Thanks, Michelle.
thank you. Thank you,
Yeah.
guys.
Yeah, thank you guys so much for this.
And thanks to everybody who tuned in to watch and who is watching. We really appreciate you paying attention to this and for listening to us. So thank you.
And this conversation will be morphed a bit in our third and final pop-up for this limited series, not saying there won't be more, on private public healthcare next week. So please join us then. Dr. Hillner, Dr. Meyer, thank you very much. Please remain in the backstage area as we say goodbye.
Thanks.